Okay friends, good morning to everyone. In earlier class, we have discussed the cholinergic agonist, and now the next class, this class is the cholinesterase inhibitors and their poisoning. Cholinesterase inhibitors means the drug inhibit the cholinesterase, anticholinesterase. Anticholinesterase means which inhibit the enzymes responsible for degradation of acetylcholine, that is the cholinesterase. Once the degradation of this enzyme, the degradation of this acetylcholine is inhibited, prevented by inhibiting this enzyme, you can say in other way the concentration of acetylcholine is increased. It means ultimately this anticholinesterase increases the concentration of acetylcholine, or you can say provoke the activity of acetylcholine, that is the indirect cholinomimetics, because it not directly bind to the cholinergic receptor. It increases the concentration of acetylcholine by inhibiting its degradation, and we can say it's indirectly cholinomimetics. And when we see the structure of this compound, basically classified in two broad categories. One is the organophosphate. This is the typical portion of organophosphate. And this R1 is the maybe alkyl group, aryl group, depending upon the compound. And this R2 is also alkyl aryl group, and X is maybe bronze chain substituted groups. And basic moieties of organophosphate is this, and it is very lipophilic. Because it is very lipophilic, it can get easily absorbed even through the mucous membrane or intact skin, and that is the major things responsible for the organophosphate poisonings what farmers are using in the form of insecticides. Another compound is the carbamates. These are the basic carbon moieties, and these are basic structure. And R1 may be methyl aromatic or benzimidazole group, thus R2 is the aromatic or aliphatic. And this is the organophosphate, and this is the carbamate. These are the basic classification of broad classification of anticholinesterases. When you see individual drug, one is the reversible inhibitor, the other is the irreversible inhibitor. The enzymes cholinesterase, which degrade the acetylcholine, is inhibited by all these compounds. And one is the reversible, it means it bind to the enzyme, same enzyme, and these drugs get easily metabolized, and you can say T-half is comparatively lower as compared to the irreversible, and that's why it's known as the reversible. Irreversible means once it get bind to the enzymes, it inhibited the enzymes at comparatively the longer duration, and especially in the case of the phosphate, organophosphate compound, the other enzymes may produces before when this enzyme get inhibited and permanently get inhibited. At the same time, the fresh enzyme get produces. You can say that's why it is the irreversible. It means its metabolizing time is comparatively higher. That's why the irreversible. And we go about the reversible, we can classify into the carbamate and acridine. Carbamate means physostigmine, neostigmine, pyridostigmine, endorphinium, rivastigmine, galantamine, and so on, and donepezil. Acridine compounds is tacridine. It is the only this among these things may be used for the earlier used for the Alzheimer's disease because it can cross the blood-brain barrier. Irreversible, organophosphate and carbamate. In organophosphate, ecothiophosphat, malathion, diazion, and these are the carbamates compounds. It is indirectly cholinomimetic compounds. It means it is the acetylcholine, and this acetylcholine get metabolized by cholinesterase into its component choline and acetate. Once it reaches into the synapse or the neuromuscular junctions, and when you give this drug in the presence of this anticholinesterases, it inhibits the enzyme which is responsible for the metabolism of this acetylcholine. It means the metabolism of this enzyme is inhibited. It means the availability of acetylcholine get increases, and because acetylcholine exert its effect by activating both receptor, nicotinic and muscarinic receptor, and you can say when you give the anticholinesterases, it exerts similar effect like the acetylcholine, that is the indirectly acting cholinomimetics by activating both of receptor, nicotinic as well as muscarinic, without directly binding to these receptor. It inhibits the enzymes and facilitate the, you can say, binding of this acetylcholine to either of receptor by increasing its concentration. That's why it's known as the indirect cholinomimetics. Now comes what is the exact role, exact mechanism. It is the first thing when you are discussing about the active binding site of cholinesterase having two portions. One is the anionic binding site, one is the asteretic, and these are the polars. And this is the acetylcholine. This acetylcholine is the partially polar compound. This positive charge having attachment to this negative anionic site, and this other portion may attach to this asteretic site like this. And once this acetylcholine fit into this active portion of acetylcholinesterases, and it having some binding to the asteretic site, and these are the carbon here, the hydrolysis take place, and next step, you can see the acetylcholine get hydrolyzed into acetate and this choline, and it get degraded. It means when this acetylcholine come in contact to the active site of choline esterases, it get rapidly degraded into its component. And once this acetylcholine get degraded, its activity is inhibited because there is no more acetylcholine to act on their respective binding site, either maybe cholinergic or maybe nicotinic or muscarinic receptor. And this is the very fast process. Once this acetylcholine bind to this active site, it gets rapidly degraded. And in the presence of this organophosphate, or you can say acetylcholine esterase inhibitors, when you are discussing the acetylcholine esterase inhibitors, the binding of this acetylcholine esterase inhibitor is not similar as to the acetylcholine. For example, adrophonium and tacrin bind to this anionic site, and phosphate binding to the asteretic site. When this phosphate bind to the asteretic site, its degradation, you can say its hydrolysis, is very slow. Here it may get hydrolyzed but take much time, and at the time new enzyme gets synthesized, and that's why you can say it is an irreversible inhibitor. And like this, and when you give the compound, and that is responsible for the poisoning, when a person have accidentally taken this acetylcholine esterase, especially organophosphate, it means the availability of acetylcholine is there, and it leads to the organophosphate poisoning. And at that time, when we prefer this compound, AIIMS having more electronegative compound, it may attach to this phosphate and forcefully try to detach from this binding site, and therefore this binding site of this enzyme get free, and that's why this AIIMS is the one of the drug of choice in the organophosphate poisoning. We had discussed what is the exact role of anticholine esterase in inhibiting the activity of this enzyme. And when we see the pharmacological effect of the anticholine esterase is similar to the acetylcholine, because it increases the concentration of acetylcholine and may exert the muscarinic nicotinic effect. When we are discussing about the CNS effect, excitation, convulsion, respiratory failure. For the lipid soluble anticholine esterases, which can cross the blood-brain barrier and reach to the heart center, physostigmine-like compound. Okay, and muscarinic action. This, for example, on the eye, it act on the circular muscles, and by activating the M3 receptor, and causes meiosis, decrease the pupil size, and contract to the ciliary muscles, and therefore may responsible for the decrease of the intraocular tension, and it may be beneficial in the case of the glaucoma patient. And the heart and endothelium, it decreases the heart rate, similarly by increasing the concentration of acetylcholine. When the acetylcholine act on the heart, especially on the M2 receptor, present on the SA node, decreases the phase slope of phase 4 diastolic depolarization of SA node, and you can say decrease the heart rate. Open the potassium channel, prevent the opening of the calcium channel. You can say acetylcholine not only decrease the heart rate, force of contraction and rate of impulse generation get also decreases. Negative inotropic, domotropic and negative chronotropic effect produced by similar like the effect of the acetylcholine. And also increase the release of nitric oxide from the endothelium. Lungs constrict the bronchi. Similar receptor, M3 receptor. GIT increase the peristaltic movement, increases the GIT secretion, gastric secretion, relaxes the sphincter, evacuation may be there. Urinary bladder, contraction of the muscles, relax the sphincter, and it act on the glands, increase the secretion of the sweat glands, salivation, lacrimation, bronchial and other intestinal secretion, and by acting on the M3 receptor. When we are discussing about the nicotinic receptor act on the neuromuscular junction and as the therapeutic dose causes muscle contraction, and toxic dose because the persistent depolarization of this on the muscular end plate causes paralysis, continuous relaxation and paralysis. Ganglia stimulate both ganglia, sympathetic as well as parasympathetic autonomic ganglia. Adrenal medulla release the catecholamines, both adrenaline and norepinephrine from the adrenal medulla. And when we are seeing the individual compound drug like the hydrophonium having the OS, this is alcoholic in nature, and reversible anticholinesterase, it may get easily metabolized as comparison to the phosphate, and polar in nature, not absorbed early, attach this hydrophonium attractant attach mainly to the anionic site by weak hydrogen bonding, while the organophosphate bind to the astatic site by covalent bond, and binding is very strong binding. That's why it's known as the irreversible. I am talking about the organophosphate, and it in the case of hydrophonium and tacrine, it bind to the anionic site and easily get metabolized. That's why it comes into reversible anticholinesterase, and duration of action is 5 to 15 minutes. Basically used in the myasthenia gravis. We will discuss later on what is the myasthenia gravis. When you are discussing about the physostigmine, it is the relatively lipophilic in nature and it easily crosses the blood-brain barrier. Also comes into the reversible anticholinesterase, not polar, lipid soluble, and also get easily absorbed by the GIT, having both activity, nicotinic and muscarinic activity, and because it can cross the blood-brain barriers, having the dominant CNS effect, and used in the glaucoma, reduce the intraocular tension, and also used for the atropine toxicity. neostigmine. When you are discussing about the neostigmine, it is also comes into the reversible anticholinesterase, having the quaternary ammonium compounds, polar compound, because it's the polar compound do not cross the blood-brain barrier, no effect on the CNS, having peripheral effect, nicotinic as well as muscarinic effect, prominent to the smooth muscles, and also used for during the myasthenia gravis. It is the first choice, and paralytic ileus and urinary retention, and also in the competitive neuromuscular blocker intoxications. Other drug, newer drug, rivastigmine, having the same mechanism of action, lipophilic, easily cross the comparatively safe as comparison to the tacrine, because tacrine can also cross the blood-brain barrier. Earlier it was used in the case of Alzheimer when these drug was not available, and these are rivastigmine is a comparatively safer drug as comparison to the tacrine, and also can cross the blood-brain barrier and may be used for the Alzheimer. Donepezil, it is a centrally acting, long half-life. This space is missing here, and suitable for OD use in the Alzheimer's disease. Similar thing is the galantamine. It is the natural alkaloids, and in addition to the weak agonistic action on the nicotinic receptor, has also having the weak agonistic action, and also used for the symptomatic relief of the Alzheimer's disease, which can cross the blood-brain barrier. Overall, when we are discussing about the use of anticholinesterase inhibitors, first and major use in the case of the glaucoma, it increases the tone of ciliary muscle and in sphincter pupils, and you can say when increases the tone of ciliary muscle and in sphincter pupils, it improves the trabecular meshes, and it facilitate like this and create the porosity and facilitate the outflow of this trabecular outflow of this fluids, ocular fluids, and that get accumulated into the chamber and decreases the intraocular pressure, and that's why it may be used in the case of the open angle glaucoma. There is a problem into the flow, and good drug is the pilocarpine, and T-off is the 4 to 6 hours. Other use in the case of the myasthenia gravis. Myasthenia gravis is the autoimmune disorder when the antibodies, especially for the NM receptor, get generated, and once the antibody on the NM receptor get generated, near about 1/3 of the receptor is unable to activate by acetylcholine, and patient feeling problem, weakness, tiredness, because there is a problem into the contraction of these muscles. Here you see the neuron, and neuron is the, and it get innervated to the skeletal muscles, and receptor is the NM receptor. These are the receptor, and when this acetylcholine releases from the terminal neurons, this acetylcholine able to exert effect by acting on this nicotinic NM receptor, and in the presence of this antibody, near about 1/3 of this whole of this receptor, this antibody, when get bind to the same receptor, the acetylcholine is not able to interact this same receptor and exert their effect. That's the basic problem of myasthenia gravis patient. And one thing is, when you give the anticholinesterase inhibitor, when the acetylcholine, whatever they get released from these neurons, and it get degraded by acetylcholinesterase. When we give the acetylcholinesterase inhibitors, it inhibits the enzymes and inhibit its degradation, and you can say its availability is more into this site, and more acetylcholine is available to act on the free receptor and improve the muscle contraction, if that may be beneficial in the case of the myasthenia gravis patient. And usually neostigmine is the drug of choice, 50 mg, because neostigmine get absorbed early for every 6 hours. Pyridostigmine is maybe other drugs, and good thing is that not need for the frequent dosing as comparison to the neostigmine. When you see other drug is the corticosteroids, it inhibits the production of antibody because of its the immunosuppressant effect. And in other research, it has been found out when you give the corticosteroids, the production of even the new receptor, nicotinic receptor, get facilitated. Other drug is the azathioprine and cyclosporine, also inhibit the antibody synthesis by affecting the T cells, but is the not good drug, having the not safe drug, having the very complex adverse effect. And plasmapheresis may be one techniques to mechanically remove this antibodies present into the blood systemic circulation. Thyroidectomy. It believes that it is the thymus gland. It is responsible for the production of this antibody. When we remove this thymus gland, it may be beneficial into the myasthenia patient. And when you give the excess of this acetylcholine esterase, it increases the concentration of acetylcholine up to the level that can cause the persistent depolarization, and you can say the paralysis like symptom get appear, further weakness get appear, and it is very difficult to diagnose, investigate either it is the myasthenic patient is there or it is due to the overdose of the acetylcholine esterase inhibitors. And we can easily detect by giving the adrophonia. And if there is an improvement, it means the myasthenic patient. If improvement, that is the myasthenic and crisis, and is a no improvement, is the worsening with the cholinergic crisis. other uses in the urinary retention, and that is the methanochol or neostigmine, and also used in the xerostomia, that is the dryness of the colon, that is the pilocarpine, and for the Alzheimer's disease, donepezil, rivaroxaban, galantamine are frequently used. We can summarize the uses of carbamate esters. Myasthenia gravis, paralytic ileus, urinary retention, and ocular toxicity, toxicity, and these are the kinetics. These are the action both by nicotinic and muscarinic. These are the 0.5 to 2 hours, and drug is the neostigmine. And we are discussing about the physostigmine, is the lipophilic drug, and similar T-half, and by similar way used for the atropine toxicity and glaucoma. Pyridostigmine, same drug like the neostigmine, and it is the polar to 3 to 6 hours, having the good T-half as compared to the neostigmine, and good drug for the myasthenia gravis. No need for the frequent administration as needed into the case of the neostigmine. And these are the drug aminonium for the myasthenia gravis, and similar T-half is the 4 to 8 hours. Now discuss about the poisoning. Excessive dose of the anticholine esterase. This anticholine esterase or the web poisoning is very common, especially in the rural areas of other poor countries where the people are not aware about this poisoning, and farmers are using in the for use of the insecticide, and these are the common available preparation that farmers are using. How you detect, how you diagnose the patient having the organophosphate poisoning? First is the irritation of eyes, salivation, lacrimation, sweating, weakness, bradycardia, even tachycardia, fall in BP, problem in the respiration, everything that is the excessive action of the acetylcholine. And most common feature is the meiosis. These are the common symptoms for the patient of anticholine esterase poisoning. I am repeating: irritation of eye, lacrimation, salivation, sweating, decrease of the blood pressure, problem in the respiration, maybe bradycardia or tachycardia is not fixed, arrhythmia, you can say arrhythmia, and these are the common problem and major common symptoms and major things you can diagnose by the pinpoint pupils. For the management, if you don't have any drugs at the time, physically detach, wash out the mucosal membrane or the skin, breathe the fresh air. If blood pressure decreases, you can maintain the blood pressure by the other way, by the infusion. If problem in the respiration, you may apply for the positive pressure. These are the non-pharmacological management of poisoning of the anticholine esterase inhibitor. And the main drug is the atropine. where atropine, at the which situation atropine is required. If problem in the breathing, there is maybe bronchospasm. If fall in BP, tremendous fall in BP, bradycardia is there, excessive sweating is there, and pupil size is very less, and hypotension, you can say BP when get decreases, and these condition when get persist, and you know that patient is having the exposure of anticoagulant estrase, at that time you can use atropine. Other drug is the AIIMS, and other is the adjunctive treatment. When we are talking about the atropine, what is mechanism? It blocks the muscarinic effect due to the excessive firing of the acetylcholine, excessive bombarding of the acetylcholine. The competitive inhibitor control the symptoms of the symptoms determined to dose get titrated, initial dose and up to the you can say 200 mg we can use in a day, and we can titrate the dose per day. I am talking about the per day. That is the end point, how you prevent when the pupil size get normalized, secretion get reduced, heart rate get increased more than 80, blood pressure get normalized, we can stop this giving of the atropine. Loading dose maybe start for 2 mg and 2 mg, 4 mg. We can use and increases the dose to, in every 5 to 10 minutes, and maximum dose we can use, we can titrate it depend upon the patient to patient, and maximum dose the 200 mg per day. That is the maintenance dose. Once this patient get normalized, we can give 10 to 20% of the loading dose per hour. And these are the end point when the problem in the breathing get disappear, heart rate get optimum more than 80 beats per minute, we can stop. If toxicity is there, we can use further the measure with the common figure of the organophosphate poisonings. AIIMS is the drugs basically used for the organophosphate poisoning. When the organophosphate having the specific binding site on the asterotic site, and in the presence of this AIIMS, because organophosphate having the covalent binding to the asterotic site, and you can say it is a very permanently binding. And when you give the AIIMS presence, because AIIMS consists of a lot of the electronegative atoms in the AIIMS molecules, when you give the AIIMS, it bind to the organophosphate and try to forcefully detach from the binding site. And you can say this AIIMS is the good drug, especially for the organophosphate poisoning, which binded to on the asterotic site. And it is not the drug used for all organophosphate. That's why we are putting 0 to 0 means no use if the organophosphate is not there, and it is the per gram per dish. And intermittent bolus or the infusion, ineffective against the other organophosphate poison, drug of choice for the organophosphate poison. And these are the other things is the magnesium. Reduces the acetylcholine release. You can say magnesium is the physiological antagonist of the calcium. Calcium need for the fusion of the vesicle to release the acetylcholine. When you give the magnesium, reduces the acetylcholine release, block the presynaptic calcium channels, and decreases the toxicity in animal model, but not used commonly. It is the adjunctive drugs. Okay, so friends, we had discussed the anticholinesterase inhibitors, or you can say anticholinesterase or cholinesterase inhibitors and their poisoning. I hope you hear my lecture carefully. If you have any problem, any doubt, you can give me email by hnyadav@gmail.com. I am repeating my email, that is hnyadav@gmail.com. Thank you very much.